Good morning. I thanks the organizing committee of the ISMPO to associate me with this important meeting. The topic which is given to me is how best to incorporate novel agents in the management of newly diagnosed multiple myeloma. Now let's start with few facts about multiple myeloma. Multiple myeloma constitutes 10% of hematological malignancies. The median age is 65 years. That means it happens mostly in the elderly age group. Though in the Indian setting, we are more used to see patients in the younger population, 40 years or 45, 50 years. But the median age remains high. It's still an incurable malignancy. And even if you diagnose a patient of multiple myeloma, you have 10 patients of multiple myeloma, all will behave differently. That means they are multiple myelomas. Current treatment only prolongs the survival, even though we have plenty of medicines and maybe a small percentage can be cured. But the current understanding is that we can only prolong survival. However, the median survival, which was used to be 3 years around 2 decades ago, is now ranging more than 10 years in most patients. This is one paper which is published in Leukemia 2017, which tells about the trends in overall survival and cost of multiple myeloma from 2000 to 2014. And in this graph, you can see that as from 2006 to 7, 8 and 9, 10 and 12, gradually the multiple myeloma patients are living longer. And obviously this is up to 2012, and this graph I'm sure is here at this point. So the goals of treatment of multiple myeloma are: number one, reverse the ongoing or impending organ dysfunction which is going on, mostly which is noted by CRAB, hypercalcemia, renal failure, anemia and bone lesions. Once you give treatment, the idea is to improve the progression-free survival and overall survival of these patients. The therapy which is given should be safe and also maintain the quality of life. And the last is the cost effectiveness of the therapy. As you are not going to cure, so you have to decide your therapy which can give good quality of life for a prolonged period of time and is cost effective also. Now the treatment of newly diagnosed multiple myeloma is divided into what is like treatment of acute leukemia. So you have induction therapy, you have consolidation therapy, and you have maintenance therapy. The good thing is, as I said previously, that we have a lot of treatment options these days. And these treatment options can be divided into chemotherapy, corticosteroids, immunomodulatory drugs, proteasome inhibitors, cellular therapy in the form of auto or allogeneic hematopoietic cell transplantation, anti-CD38 antibodies, HDAC inhibitors, targeted therapies, antibody drug conjugates, and cellular therapies. And the last is bispecifics. So in chemotherapy, you have the old drugs like melphalan, cyclophosphamide, bendamustine, doxorubicin, cisplatin, vincristine. Corticosteroids, mostly either it is the dexamethasone or prednisolone which is used. IMiDs came into pictures 2 decades ago: thalidomide, then lenalidomide, and now pomalidomide. Proteasome inhibitors followed subsequently to IMiDs. Bottiland's was the first one, then carfilzomib, and oral proteasome inhibitor ixazomib. The anti-CD38 antibodies like daratumumab, isatuximab, and anti-SLAM F7 antibody elotuzumab. HDAC inhibitors like penobinostats, although they are withdrawn from the market now. Targeted therapies specifically for 11-14 myeloma or amyloidosis, venetoclax. Antibody drug conjugates, belantamab. Cellular therapies, CAR T cell therapy. ID cell is already approved and CAR T cell is likely to get approved. And the bispecifics, which are right now not approved and they are in the pipeline. So once we have plenty of these medicines, now what are the variables that affect our induction regimen in multiple myeloma? And these you can divide into whether it is disease related variables, patient related variables, or miscellaneous. When we talk about disease related variables, these are whether the patient falls into a standard risk or a high risk, whether the patient has renal failure at the time of diagnosis, extramedullary disease, plasma cell leukemia, what is the ISS stage or the revised ISS stage. Coming to the patient related variables, these are the age of the patient. As the age goes up, the tolerability goes down, and many of the therapies you cannot give at an older age. The transplant eligibility, although all patients are taken up, they are eligible for transplant, but many times because of the age and comorbidities, these patients cannot tolerate high dose chemotherapy, and hence they are transplant ineligible. Comorbidities, as I said already, presence of diabetes, heart failure, renal failure, or other comorbidities. What is the finances or insurance status of the patient? As I said, this treatment is lifelong, so we have to make a regimen which patient can continue. Even if there is a relapse, then he should have finances to continue the regimens. Nutritional status of the patient. Although serum albumin is a good parameter to classify the patient into different ISS, but some patients have very poor nutritional status because of many factors and poor performance status also, and hence you cannot give high dose chemotherapy to these patients. Fertility is other one which you can see and in the patient and then decide about the therapy. Some of the miscellaneous causes are like availability of drugs. Some of the drugs may not be available, some of the therapies may not be available in that particular center or in that country. For example, CAR T cells right now are not available for myeloma patients in India. Monitoring facility. At some centers, they may not have to properly monitor the patient. Family support, I feel, is very, very important, which can really help the patients to go through the whole treatment. Okay, so now after knowing about what are the drugs which are available and the variables which affect the treatment, the questions which comes to our mind are, in the induction therapy, what is the best induction therapy? Whether we give 2 drugs, 3 drugs or 4 drugs combination. The good, whether the bortezomib is good or carfilzomib is good in the induction therapy. Similarly, in the IMiDs, thalidomide versus lenalidomide versus alkylator cyclophosphamide. What is the role of addition of anti-CD38 antibody like daratumumab in induction therapy? Then in consolidation therapy, what is the exact role of an auto hematopoietic cell transplant? And how long therapy to continue if transplant eligible or transplant ineligible? And in the maintenance therapy, whether you give single agent lenalidomide or double agents. So we will discuss some of these questions in the subsequent slides. The first question obviously is doublet versus triplet, and this debate was long settled in 2010 by this IMF study, uh, which comparing the bortezomib with thalidomide plus dexamethasone. That means Vtd compared with thalidomide plus dexamethasone as induction therapy before and consolidation therapy after double auto transplant in newly diagnosed multiple myeloma patient. This was a phase 3 randomized studies, and in this study there was a clear uh, improvement in the complete or near complete response in patients receiving triplet versus doublet, and there was a overall survival difference. And based on that, in 2010, that means almost a decade back, therapy, the standard of therapy was triplet consisting of bortezomib, thalidomide, and dexamethasone. This was the editorial which was written by Paul G. Richardson in 2010. However, in India, we have been using lot of centers were using or are still using bortezomib, cyclophosphamide, and dexamethasone. So VCD regimen. So there is a comparison with VCD versus VTD regimen. So both are triple drugs in newly diagnosed patient. This is a meta-analysis which is published in 2014. And in this meta-analysis, based on the different studies, although there is no direct comparison of these two studies, but from various other studies, the meta-analysis which was done showed significantly higher complete or near complete response, 34% versus 6%, as well as a higher very good partial response or better patients receiving VTD therapy versus VCD therapy. And this is shown in this table also. The post-induction response rates, VTD versus VCD, and you can see the CR or near CR rates and the VGPR rates are better with VTD therapy. So based on this, generally we do not recommend VCD therapy in otherwise fit patient of multiple myeloma these days. Then we had a comparison of Lendexa versus Bottiland Dexa. This is a SWOG S 0777 trial which was published in 2016, and in this regimen again triplet were better than doublet, and you can see the confirmed response, very partial response are better in patient group who received triplet than the doublet. So the SWOG trial showed that all novel triple drug combination, that means bortezomib, lenalidomide, used in the absence of an auto transplant is superior to double novel agents in terms of PFS as well as OS. So from 2014 or 15 onwards, most centers in the world, people have shifted to Bottiland Dexa, or what we call as VRD or RVD, as the induction therapy in newly diagnosed multiple myeloma patients. So in terms of overall response rates, VRD is better than VTT and then VCT. Although there is no direct comparison of VTT with VRD or VCT with VTT or VRD. Now, VCD still has a place, especially in patients who present with acute renal injury due to cause nephropathy. And here in one trial which is published a couple of years ago, showed doublet versus triplet, comparing the Dexa versus Dexa plus cyclophosphamide. And in this trial, they showed at 3 months there was no difference. However, the study is not received very well because already the therapy which is proven is the triplet are better than doublet. However, what this study shows is that in patients with renal failure, bortezomib is the most effective, and whether you give VCT or VD, at 3 months the response rates are shown in this graph. So in patients presented with renal failure, VCT or VD is good enough for the initial therapy because the mortality is quite high in these patients, patients who present with renal failure. Now what about quadruplet or addition of daratumumab and anti-CD38 antibody? Most of you may be familiar with the Cassiopeia trial, which is bortezomib, thalidomide and dexamethasone with or without daratumumab. This is again a phase 3 study by the French group. It clearly shows that the stringent complete response and complete response are better if DARA is used upfront in the VTD regimen. So VTD actually is still the most common kind of a regimen followed in the European countries, and that's why they compare VTD with DARA VTD with VTD. Even the MRD negative status is better when you are using DARA upfront in the induction therapy. And you can see that this forest kind of a graph that it favors the DVTD regimen. So the interpretation DVTD before and after auto transplant improves depth of response and PFS with acceptable toxicity safety. Now similarly we have a Griffin trial. It's a phase 2 trial which comparing DARA Len Boti Dexa with Bottiland Dexa VRD versus DARA VRD, and here again this shows the MRD negativity rate are better with when you use DARA in the induction therapy. And in this forest kind of an analysis, DARA RBD is better than RBD in terms of most situations, including in high risk. This is the percentage surviving without progressions. You can say 89 versus 95, RBD versus DARA RBD. So in the Griffin trial, the DRBD improves stringent CR rates and MRD negativity versus RBD, both which deepen over time, and there are no new safety concerns. So addition of daratumumab in VTD or VRD induction does lead to increase in the MRD negative rates. Now the survival is so long, whether this will ultimately improve the overall survival or not, we don't know with the time factor will tell, but there is a definite difference between the PFS. Now the other commonly asked question is which proteasome inhibitor to use, carfilzomib or bortezomib upfront. And there was a lot of hype last year about this 48 trial, which is a phase 2 trial comparing carfilzomib with cyclophosphamide and dexamethasone versus carfilzomib Lendexa plus auto, carfilzomib Lendexa followed by maintenance with carfilz plus Len. So 3 drug comparison: carfilzomib cyclophosphamide Dexa, carfilzomib Lendexa, and then in maintenance carfil Len versus Len alone. So in this trial, the good thing is the overall response rates were quite good, more than 90% in all the 3 arms. So KRD followed by transplant, KRD 12 and KCD. However, when you decipher it further, obviously KCD is inferior. So as I said previously, so VCD and KCD, that means cyclophosphamide upfront is inferior in terms of achieving response rates as compared to Len or Thal. However, when you look at the MRD, the transplant obviously initial KRD followed by transplant does lead to better MRD negative rates, 69% versus 80%. In the maintenance therapy also, even though both are equal, but you can see some difference in the response rates when you're using Len versus carfil plus Len. Especially this is useful in those patients who are high risk. So this is the progression-free survival, and you can see KRD plus followed by transplant is way ahead with the KCD plus transplant, and similarly in the maintenance therapy, Carfil plus Len is better than Len alone. The p-value is 0.023. Obviously, then you add DARA to this regimen. So what happens? This is a master trial, which is again published last month only. DARA, Carfil, and Dexa, and this trial is also looking at the MRD, whether you can stop the maintenance if the person is MRD negative. So you can see these graphs. The people with the high risk cytogenetic abnormalities, they did better than those patients with ultra high risk. And in these patients, if they are MRD negative, they have stopped, and obviously we would know on follow up of these patients. So for patients with 0 or 1 high risk cytogenetic abnormalities, this strategy creates the opportunity of MRD surveillance as an alternative to indefinite maintenance therapy. So based on these studies, the summary is, even though carfilzomib appears to be superior to bortezomib in the upfront setting in high risk, the risk benefit in our setting is debatable, as if you remember, the cost effectiveness is very, very important in these patients. Probably if you ask me theoretically, I would say young patients who has no problem in finances, maybe high risk young patient is the best person to receive carfilzomib based induction therapy. So the induction therapy is quite centered around achieving stringent CR and or MRD negative status. So I think it is a good time to revise the response criteria in myeloma, which are given by eye interpretation. So the PR rates is when there is more than 50% reduction of serum M protein. VGPR when it is M band is negative, there is 90% reduction, but immunofixation is positive, and the CR rates are negative immunofixation on serum and urine, disappearance of insufficient plasmacytomas, and less than 5% plasma cells in bone. Stringent CR when there is a normal relation ratio also, and there is no plasma cells. MRD negative by flow or next generation. This is all deeper revision which these days we focus on, because deeper revisions actually leads to prolongation of survival. So the MRD negative status, if you're using VTD, DARA VTD, VRD, DARA VRD, KRD, and DARA KRD, look at as you intensify the therapy, the MRD negative rates goes up. However, again, this is quite costly, and I'm not sure whether in Indian setting how many patients can afford this kind of a regimen. So summary of induction therapy, VRD or VCD in case of renal failure, and upgrade to VRD if creatinine normalizes. Add DARA in induction if affordable, KRD in high risk young patients if affordable. Now the next question is duration of induction therapy. You generally take up the patient for an auto SCT, which is a consolidation therapy after 4 cycles. But sometimes, in our setting, patients take time and can continue up to 9 cycles this regimen. And however, lenalidomide can be dropped with standard risk patient after 6 cycles, whereas in high risk patient you have to continue then or replace with thalidomide or cyclophosphamide. We don't know the outcome of those patients. That is a meeting of research. So the impact of duration of induction therapy on survival in newly diagnosed patients. So 2 cohort, they looked at where they irrespective of response took up the patient after 4 cycles of transplant versus when induction therapy was continued for more than 4 months, and there was no difference in overall survival in the 2 groups. So this paper concluded that you don't actually prolong you don't look at the response waiting for VGPR or PR or CR. Just take up the patient for transplant. So for transplant ineligible patients, so generally the therapy is continued for 6 to 9 cycles. And the other option these patients are instead of Bottiland, you can use DARA, Lendexa, which is actually a very good kind of a regimen, and you can see the PFS comparing Lendexa with DARA Lendexa. And this is a Maya trial and Alzheimer trial. Again, they look at the MRD negativity rates. People who are MRD negative are doing much better than those patients who are MRD positive. So induction therapy in Indian setting, VRD, DARA, VRD, KRD, transplant eligible, DARA, Lendexa, or VRD light. I generally prefer VRD light in most of these patients. So the consolidation therapy is generally with transplant, and this is one of the landmark paper from the French group looking at the VRD and transplantation. So here they gave 3 cycles of RVD, then consolidation therapy, either 5 additional cycles of RVD or high dose melphalan with transplant. You can see the transplant group did better in terms of complete response as well as MRD negativity. However, the overall response rate is the same, meaning thereby that you can do the transplant upfront or even delay it. The response rates are obviously better if you do the transplant. So the PFS is definitely better if these patients are taken up for consolidation as transplant. Whereas the OS is not different because of the availability of better therapies, salvage therapies. So consolidation therapy, transplant with melphalan 140 to 200. For ineligible patients, you continue 6 to 9 cycles. So this is a consolidation therapy for these patients. The maintenance therapy is clear after the publication of these reports that LEN is better than placebo, both in terms of PFS as well as OS. And we have a CalGB Alliance study also, again looking at the same. The LEN is better in terms of PFS as well as the OS. So the algorithm which is given by Vincent and Shaji is they are dividing into standard risk, intermediate, high risk. I would say that 14 is now also taken as standard risk. So you give VRD or DARA VRD based regimen in these patients who are transplant ineligible. Continue with therapy indefinitely. Generally, for high risk, you consider double body and LEN as maintenance. For transplant eligible patients, 4 cycles, collect stem cells, take up for transplant. That's what happens in other patients, and continue then, I will say, indefinite therapy, or sometimes you can give both and then together. So concluding, we have come a long way in the treatment of myeloma. Median survival from less than a year now is more than 10 years in low risk myeloma, the standard risk myeloma. The induction therapy in current era consists of proteasome inhibitor with imid and corticosteroid triplet, and you can DARA if the patient is affordable. Transplant eligible patient undergo auto transplant after 4 to 6 cycles of induction. Patient achieving MRD negative status at day 100 have excellent long-term outcome. All patients post-transplant get either LEN or BOTI or both based maintenance therapy indefinitely until progression or intolerability. Transplant eligible patients get continuous therapy at least for 9 to 12 cycles, followed by maintenance therapy indefinitely until progression or intolerability. With that, I thank you very much.
One quick and which is probably the most frequent question which is asked is daratumab showing some activity in upfront setting, especially the non-transplant eligible part. So do you see any subset which would particularly be benefiting by DARA, and you would be probably insisting on treating such patient with daratumab in the first go, sir?
Thank you. Sorry, actually today there were 2 meetings, so I recorded this presentation yesterday, and what I could see there was some disturbance, so I'm sorry for that. I hope you were able to get some idea about the presentation. But I think we can clarify some of these questions, and this question which you have asked is very valid about adding daratumab upfront in the induction therapy. So as I said before, in our setting, the DARA is quite costly. Uh, so it is very difficult to actually to answer whether to add DARA upfront in if you are giving VRD regimen or not, but probably somebody who is high risk cytogenetics, where we feel that achieving an MRD negative status is very, very important. Maybe in those setting, I would say that we can add DARA if the patient is affordable. In a standard risk patient, it is okay if you use VRD or DARA VRD.
Yeah. So besides cost, another concern is tolerance of our patient, because they come with many time renal dysfunction and infection quite alike. So and there is some data from your centers also. Do you see any increased risk in our patient when we use DARA across the board for all our patients?
So we recently just completed, looking at the infections risk in these patients. The infectious mortality in the first 60 days in our patient is approximately 20.5%. And in this COVID era, actually quite a good number of patients had COVID infection also. And patients who had severe COVID, in fact, nobody survived, whereas patients with mild to moderate COVID, they survived. Uh, we have now started, a regular practice of giving pneumococcal vaccine as well as flu shot to all these patients. We did almost a similar kind of a study 2 years back also, where the mortality was quite high. And now with the routine immunization, we have seen that the mortality has come down. So I would suggest that, we should try to push immunization of all these patients of multiple myeloma, even though we know that they may not form the proper antibodies as compared to the normal people. But still, I think giving immunization to these patients is important to decrease the mortality, because infectious related mortality is still high in our population. And obviously, if you're adding DARA to that, which suppresses the plasma cells, and it suppresses the normal plasma cells also. So obviously the immunity is going to go down.
Yes, sir. So thank you for that very important message from your study, sir. Sir, last question, which is not really related to the upfront setting. We have this Bellini trial and a bit of disappointment there, sir. But if you look at the hazard in translocation 1114 and BCL2 overexpression, it is 0.12, which is quite impressive hazard. So do you see this drug is being repurposed or would be studied further, or do you think it's end of when in multiple myeloma?
I think so that for 1114 patients specifically, even though in the Bellini trial they looked at the overall survival, which was lowered in those patients. However, in the subset of patients of 1114, definitely it made a lot of difference. So I would say that even though you may not use it in the upfront setting or in the first relapse setting, but definitely this is a good drug to be used in the second or subsequent relapses, particularly in 1114 patients who are either myeloma patients or amyloid patients.
Yeah. Thank you, sir. And in view of interest of time, I hand it over to chairperson back. Thank you.
Thank you.